Okay,
All right,
you ready?
yeah, we're ready.
Okay. Russell, knock knock.
Really?
Yes, I think it's cool.
Okay, who is there?
The Affordable Care Act.
All right, I'll bite. The Affordable Care Act, who?
Well, that's really as far as I got.
Oh.
But Mary Alice Jackson is here to tell us about the Affordable Care Act. She is a partner in the firm of Boyer & Jackson, PA, with offices in Austin, Texas, and Sarasota, Florida. She's a fellow of the National Academy of Elder Law Attorneys, and she is board certified in elder law by the Florida Bar. Mary Alice's practice focuses on special needs trust planning, long-term care counseling, estate planning, and probate. She's AV rated by Martindale-Hubbell and has been named as one of Florida's legal elite by Florida Trend magazine and as a Florida super lawyer. She is an adjunct professor at Stetson University College of Law Elder Law LLM program and is a member of the advisory board for the Center for Excellence in Elder Law at Stetson, which is also her alma mater. She's spoken and written on the Affordable Care Act for lay and professional audiences since the act was passed in 2010. So help us welcome Mary Alice Jackson.
Thank you. As I was telling them, if any of you need to know where the airport garden Hilton is, I'm a person who can tell you. So it really isn't any help at all to have a GPS when it doesn't want to go where you want to go. And I don't know of a GPS system that really understands the frontage roads in Texas. So in any event, that's not why I'm here. And I appreciate the introduction. I have very much enjoyed beginning my practice in Austin in the last few years. And my first caveat of the day, and there will be many, is that although I have spoken and read about this topic since the law was passed, every day I go back and go, really? Is that what it meant? So if I say something that you say she's completely off base, save the question. Hopefully that won't go quite that far. Is it echoing to you? Okay. Does it echo if I do that? Okay. I'm going to eat this microphone. No, I was in the middle of caveats, but I tend to get really worked up about things. Maybe this will work better. I don't lean well. So in getting worked up about things, I talk about them, and I may emphasize one point, which for you is, I don't mean it to take on quite as much importance, perhaps in your mind, as it does in mine. Let's see, what was my last caveat? This is a gigantic program. There's nothing small, easy, or understandable about it. So I think that we all need to be very, very patient as we see it unroll and do our best to understand what it is. And with that, what I'm going to start with is not on your slide, but is something that I teach my students. I know the echo is it okay? All right. It is something that I teach my students in my long-term care planning class that I teach for the LLM. And I think it's really important, and I'm going to give you a 5-minute history on how we got to this point in what we can loosely call national health care. In 1905, a group from the American Association of Labor Leaders, which was a precursor to the AFL-CIO, banded together and passed workers' compensation laws in almost all 50 states, because at that point, if you think about society in 1905, working in industry and working in mines and those kind of things, there were a tremendous number of accidents. There were a lot of injuries on the job, and there was no medical care for people. I mean, certainly there was no, unemployment compensation or any of that, but there was no medical care. And overseas, in the Western European countries, national health insurance had become an issue and had been passed in France and Germany. So the folks from the AALL got together, they passed the workers' comp laws, and then they got together with a number of other groups, including the AMA and, other folks, it's leaving the across the top of my mind, and talked about, okay, how do we get together? We need a system of national health care like they're going to have overseas, and so that we can make sure that our people who are getting injured in these accidents and getting ill and children with diseases, that everybody has health care coverage. So there was a great groundswell in 1905 because there was no Twitter, there was no Facebook page. There was just a real desire to make sure that people had some care. Very quickly after that, after these initiatives began, there began to be some second thoughts on the part of some of the parties. And so this long road began because interest groups popped up, insurance companies, other healthcare providers, other groups on behalf of working people. And I found it particularly fascinating about the AMA because the AMA was split into two factions. While it was initially in favor of healthcare coverage for all Americans, pretty soon there became a divergence between the people who were providing the care, who really wanted this because instead of being paid in chickens and hens and whatever they could find, they might actually get real money, and the researchers, who were afraid that if all the money went to the practitioners, they wouldn't have enough money to do the medical research that they knew was necessary to get us to where we were. So what happened after that, number one, this has been a very long quest towards national coverage. And I'm not here to espouse a view, good, bad, or indifferent. I have views, but you don't need to hear them. So, but there began this quest. So the first thing that happened was the Social Security Act in 1935, and proponents of national health care had been working until that point, but as we know, politically speaking, it just wasn't going to happen. So they said, okay, between the two, health care and Social Security benefits after retirement, we'll go with Social Security. And then we popped up, and this debate went on, it kind of abated during the Second World War, but then it came back with a vengeance, and there was a lot of conversation about, okay, let's do national health insurance for everyone, but people couldn't agree. And so in 1965, we got Medicare for retired people. So that's been our national health insurance program, has been Medicare. Interestingly, it was the Republican contingent in Congress who suggested the idea of Medicaid. Well, let's have medical coverage at least for the poor, women, children, pregnant people, and people who were indigent. And unfortunately for all of us, Medicaid then became a very limited and stigmatized program when it came towards providing care as time went on, because demographically things have changed so dramatically since that time. And any of you who work with aging, as the doctor was saying before me, know that when we're looking at long-term care supports and services, we don't get any help for health care there. So, but that was the political compromise then. It was, okay, we'll get it for older people. And so then fast forward to where we are now. It's not as if this has just popped up. It took 105 years to get from a beginning conversation to the Affordable Care Act. I will never refer to it as ObamaCare. I think it politicizes the issue. I don't think it is ObamaCare. It's the Affordable Care Act. It's healthcare reform. It's whatever you want to call it. Basically, it's here. So it stopped knocking on the door. We're knocking on its door. I really had to laugh earlier this week when there were all these news stories about, you couldn't get in on the first day. How many of you go to a restaurant the first day it's opened? I don't do that. Do you really expect a program of this magnitude to work on the first day? So, I personally, I'm giving it 5 years, something like that before it is, I'm sure it's going to be a lot quicker than that. But I think it was somewhat unrealistic to have looked at the act in that way. This presentation, which always happens to me right before lunch, please go out and get a Twix bar if you need to. I'm going to try and go through very succinctly the basics of the Act. So, hopefully do it in a manner in which you won't keel over from either boredom or hunger. And the Affordable Care Act is at the door. All right. Okay, what's the big picture of the ACA? Basically, most U.S. citizens and legal residents have to have health insurance. Insurance companies may no longer refuse to coverage due to pre-existing conditions. These are pretty well-known facts for most folks. You can continue under regular group coverage that you already have if you are if you are employed by an employer who has group coverage, or you can purchase individually through the health insurance exchanges if you're not eligible for group coverage. So, and the exchanges are now being referred to as the marketplaces. So one of the issues in trying to understand all this is that they keep changing the terminology. So when you hear exchange, you hear marketplace now. It's slightly easier to understand. I have no idea who came up with the concept of exchange, but I found it really, really confusing for a long time. What do they mean by exchange? And in some instances, some states, and we'll talk more about this, may expand the Medicaid population to cover individuals earning up to 138% of the federal poverty level. For people who are over that level, but whose income is up to 400% of the federal poverty level, there are premium subsidies available. And up to 400% of the federal poverty level, depending upon the size of your family, can be as much as $70,000 or $80,000 a year. So there are premium subsidies available to a pretty high income level. Controversies and concerns. I could have just done the rest of the presentation on this, but let's look at what the biggest controversies and concerns have been. Mandated coverage. There are just philosophical differences about mandated coverage. And the individual mandate, which is the tax penalty for not seeking the coverage. Medicaid expansion has been controversial in state governments as well as we know, as well as in the courts. Ratings. Used to be that insurance companies could rate your premium on a number of different bases, not limited at all, actually. They just various ratings in terms of what your health situation may be, where you live, what kind of previous status you've had. Well, there was great controversy when the ACA was being passed over ratings, and what ended up happening was that you can be charged on a 3-to-1 basis based on age, so your premium can be as much as 3 times as a younger person, and 1.5-to-1 based on smoking, and there are some geographic ratings as well. So insurance companies are still allowed to do age rating, smoking rating, geographic rating, and there are 1 or 2 others. So, but other than that, everybody's on the same playing field when it comes to what your premium can be. There are penalties for large employers, 50 employers plus, who don't participate in the program and offer coverage for their employees, and I'm not going to address that issue particularly today. People are very much afraid that their employers are going to drop their group coverage and send them out into the marketplaces on their own. I'm sure that that's going to happen in some instances. There is also for employers a program called SHOP, which is a part of the ACA in which employers can actually purchase group health insurance, which has the same qualities and characteristics as you'll find through the rest of the ACA, but maybe at a lower price than the employers can find. I know as a small business person myself that at one point about 8 years ago, we were paying $70,000 a year to cover 7 employees. I know, the price is just unbelievable. It does not cover long-term care. We're not here talking about long-term supports and services. Pre-existing conditions, all of those things, still matter. So you're not going to pay for home and community-based care for individuals who are not on Medicaid through this. You're not going to pay for nursing home care. We're still stuck on many of those issues. And I think if you see it along that continuum from 1905, I hope it's not going to take until 2105 because people can't wait on long-term care issues, but that's still part of the continuum. And then overwhelming apprehension, and I think that this is probably the biggest concern everybody has. What the heck is this thing? Was it really going to be in place, and what was going to happen? And if I go onto this website, what will happen to me, and and where will I go? So it's new. As everybody knows, the United States Supreme Court weighed in. There were a number of lawsuits, which, if you're a lawyer, were really, really interesting. If you're not a lawyer, were really, really not so interesting. But they were based on a number of constitutional principles and brought in a number of different states. And finally, when the issue came to the United States Supreme Court, there were 2 things that happened with the court. Number one, the court did not strike down the law. So that didn't happen. But the court looked at, what about the individual mandate? Can you force individuals to buy insurance? Is that a violation of one of our constitutional rights? And what the court said was it went around the argument and said, this is a tax. We are taxing you for not participating in the system. Congress has the authority to impose a tax. The mandate survives. That saved the Affordable Care Act from going down, because without the mandate and without the penalty, the program can't succeed. The program is based economically on everybody participating in the program. So, and then, very importantly, what the law had said originally was that all states who were involved with the Affordable Care Act, which was all of us, they were mandated to adopt Medicaid Expansion. So what is Medicaid Expansion? It means that up to 138% of your income, if you were between 0 and 130% of the poverty, 38% of the poverty level, you could get Medicaid coverage. No age, blind, disabled, no other factor, income only, no asset tests, you can take it. The law said if the state did not opt in to Medicaid Expansion, they were going to lose all of their Medicaid funding. You either play or you don't play. Now, the Supreme Court said, nah, can't do that. So states can opt in, but they can't lose their existing Medicaid funding if they decide to opt out. So everybody knows where Texas is. We're out. So we've opted out. And about half the states have opted in. I think it's important to understand that the states that have opted out, Florida, which is the other state in which I'm licensed, is also an opt-out. Interestingly, the governor became in favor during his re-election campaign. But the Congress, or not the Congress, the legislature in Florida voted it down, and that's happened in a number of states. So opt in, opt out, and there are interesting reasons about the discussions on the states. So that's what the court said. The act is here. The act came into effect. Everybody kept saying it wasn't going to happen. The effective date was always going to be January 1st, 2014, so it was always going to happen. Major provisions: no pre-existing condition denials, guaranteed issue and renewal. They have to give it to you and they have to renew it. No more annual and lifetime limits on your policies. The example I always give is one that's fairly personal, but it's very, very important to me, which is that my son was diagnosed with leukemia when he was 14 years old. When he was 15 years old, we had good insurance, both his dad and I, and our maximum was $2 million. When you have cancer, even in 2001, and he passed away in 2001, what had been paid out for him was $1.8 million. We were $200,000 away from not being able to continue his care. Now, we would have loved to have been able to continue his care and do whatever we could, but that's not the way that played out. So when I talk about annual and lifetime limits, those of you who have been through situations where medical care is that expensive, and in cancer it certainly is, you realize how critically important that is. Parental group coverage up to age 16 or 26, basically you can cover your kids. If you're covered, there's coverage for preventive care, and the doctor was referring to a lot of the benefits of preventive care. Tight regulation of insurance products, that has a lot to do with the exchanges that we'll talk about in a couple of minutes. There's a single form for all application. It has to be in readable font. Every application, regardless of the insurance company with whom you're applying, is the same. So apparently you're not supposed to have little teeny tiny letters of 36 pages of this agreement that you push on your iPhone that you're going to agree to even though you haven't read it. So, because who's going to want to read that? Every policy has 10 essential health benefits. And for those states who opted in to Medicaid Expansion, it's true there too. And you'll see these are the 10 things that must be covered. Oh, you'll see it in a minute. Let's see, individual mandate. There's a tax penalty. The tax amount, if you don't buy insurance or not part of a group policy, it's going to be $695 a year, or $2,085 for families, or 2.5% of the household income, whichever is less. And tax increases yearly with a cost of living increase, not surprising. And basically, it's not requiring the rest of us to subsidize the healthcare costs of the uninsured. Again, no political commentary, just factual where the economics are there. Medicare Expansion includes all non-Medicare eligible individuals under 65. Medicaid Expansion doesn't apply to Medicare eligible individuals. Talked about the benchmark essential health benefits. So what is the essential health benefit? It's minimum coverage. The insurers can decide to offer more than your 10 essential health benefits. So one of the things that you're going to be looking at if you're buying an individual policy is, okay, they've got these 10 things, what else do they have? And what are the premium comparisons? You can, by the way, if you haven't done it, go on to healthcare.gov and push Texas and push the button and put in information, and you will find out. When I did it the day before last for a client, there were 81 plans from which they could choose. So if you want to go into business explaining to people what the 81 plans are about, I think that you've got a business opportunity there. But you cannot say that there's not anything available. You cannot be altered by federal legislation. The insurance company can't come and say, well, we're going to change now. We're going to go outside the parameters of what we're allowed to do. Can't do that unless a federal law changes. It limits annual cost sharing. So in my situation, we had annual cost sharing, which meant that my ex-husband and I had to pay up to $1,800 a year out of our pockets, and then after that, we didn't have to pay any more. Again, 12 years ago, the limits to annual cost sharing right now are $5,950 for individuals and $11,900 for a family. What we've been waiting for, the 10 essential health benefits: ambulatory patient services and emergency services, hospitalization, maternity and newborn care. I love this next one: mental health and substance use disorder services, including behavioral health treatment. As a person who does a lot of special needs planning, individuals who have mental health needs, this is just huge for that population. Prescription drugs. Every plan covers prescription drugs. Rehabilitative and habilitative services and devices, laboratory services, emergency services, which I made redundant, preventive and wellness services and chronic disease management, and pediatric services, including oral and vision care. You will get these benefits. It's just what comes with the package. All right. And as I said before, there may be more or less depending upon what you want to pay for and what the insurance company might offer. What is a health insurance exchange or marketplace? How do we conceptualize what this means? Basically speaking, the exchange is the regulator of all of the plans. So it's the entity, the marketplace, that goes in and says, does your plan meet all of the criteria that we're going to look at? And if not, you got to come up to speed. And how do we provide information for individuals? What are the information portals? How do we train navigators, people who can help you get through the system? It's the system through which you go, like Alice through the looking glass, in order to get to the point where you pick your product, your insurance products. And it's the system that qualifies insurance providers for being in the system. So it can be either government or not-for-profit entities. Exchanges are entities that are not for-profit. The insurance companies are once you get through the door. We're not in this for anything other than to make sure that everybody's playing by the rules. They serve both individuals and the small businesses, the shop programs that are purchasing insurance. They provide consumer assistance. They determine eligibility. And by that I mean, are you eligible to buy private health insurance, or are you eligible to be on Medicaid? So if you're eligible on Medicaid, you stay on Medicaid. If they can get you into a private plan, or if you can be pushed into something, I don't mean push pejoratively, if you are eligible for private coverage through healthcare reform, then you will be. Determines your eligibility for the subsidies. As I said, you can get a subsidy for your premium for up to 400% of the federal poverty level. It provides public awareness and information, of which there is going to be a lot, and it monitors marketing practices. Exchange eligibility. You can be eligible to purchase through the exchange, and this is for individuals if you're a U.S. citizen or legal resident who's not eligible for Medicaid or Medicare. If you are an employee whose group benefits don't amount to 60% of covering your health care costs, so if you work for an employer who offers group benefits and you have a group policy, but it doesn't provide at least 60% of coverage of your costs, you can opt out of the group and opt into the exchange. If you are an employee whose group coverage costs more than 9.5% of your income, you can opt out of the group and buy through the exchange. And if you are a legal immigrant but are otherwise barred from Medicaid due to Medicaid eligibility, you can purchase through the exchange. So there's a pretty wide range of options there, and in particular the two in the middle that give individuals the opportunity to have coverage, have greater coverage or less expensive coverage. Premium credits. These are refundable and advanceable credits to purchase coverage through the exchange program. We talked about the income limits. The amount of the credits is provided is tied to the income level, and it's also provided in cost-sharing plans and small businesses. So, and if you go on to healthcare.gov and you put in your income level, it will pop up and tell you what your credit will be. Are you eligible for a subsidy, and if so, how much will the subsidy be? How is the insurance exchange structured? These government agencies are not-for-profits, serve distinct geographic areas. There is a public plan option that's available in each state. There are at least 2 multi-state options in each exchange, so that there's a non-governmental public plan option through the exchanges, and there's a co-op, a consumer-operated and oriented plan, which encourages nonprofit member-run insurance companies. So I know that there are a number of religious, not-for-profit member-run companies. They can also be part of the exchange, and they're encouraged to be part of the exchange structure and to continue to provide insurance through their particular entity, whatever that might be based upon. Requirements for the exchange, requirements for the insurance companies and for the exchange itself. Texas did not opt to have its own exchange. An exchange can be run by the state or it can be run by the federal government. Texas began, and a number of state agencies spent about a 2-year period of time preparing for its own exchange when the state decided, as part of its opt-out, to default to the federal government. So the exchange that Texas works under is one that is provided through the federal government, which is why you go to healthcare.gov in order to find out what a Texas resident looking for purchasing insurance through the exchange would find. So exchanges have to have customer service call centers. There have to be procedures for enrollment and credit determination. The single form plain language, as I said. You're permitted to contract with the state Medicaid agencies in order to determine eligibility and credit. So some state Medicaid agencies that are already in the eligibility business may become in the eligibility business for benefits of buying private insurance as well. And the exchange has to provide financial reporting and oversight. The exchanges go on to say that for consumer protections, there has to be a website to assist individuals in identifying coverage options. I've told you what that one is. There has to be a standard format for presenting information on benefits and coverage options. So if all those 81 options that you're going to have is going to present their information in the same format. So if you go online at Best Buy and you want to compare printers, you can do compare, compare, compare. You should be able to do the same thing looking at these 81 programs. Now, you can do United Healthcare, WellCare, whatever that's going on, and then have something to compare other than 14 different companies who state their coverage in 15 different ways. So standards have been developed for insurers to follow in providing information on benefits and on coverage. So standardization, portability, all of these things are within the concept of the exchanges and are intended to make it easy for people to enroll. If you hate it and you don't want to enroll, at least you're going to be able to get through the process itself somewhat painlessly. The provider qualifications for the insurance companies. They must meet certain marketing requirements. They have to have adequate provider networks. You can't just say, I'm in the exchange, but there are 2 doctors within the state of Texas that you can use. You have to have adequate provider networks. You have to contract with essential community providers. And this is an interesting point, I think, because a lot of providers, a lot of people who give health care are community-based and don't want to be run out of their own businesses where they know their communities, they know the needs of their communities, because the healthcare is now going to be provided by a giant corporate entity where you're never going to see a human being. The insurers have to contract with essential community providers, people who are already in the community, to provide services so that we don't lose that component of local knowledge and people who have been providing in the community for many years. There has to be outreach and enrollment assistance, and that's in the form of the navigators that you may be hearing about. I forget what else they're being referred to as, navigator. I mean, all these terms just, they're amusing sometimes, but this is the person or the entity who you can go sit down with. If you go to healthcare.gov and you go, I don't get this, or I don't think I can work my way through this, you can find out who's the navigator in San Antonio, and you can just go down and sit face to face with your navigator and say, okay, walk me through it. So each private insurance company must be accredited for quality, uniform enrollment form, and standard communication format. I realize that some of this becomes repetitive, but in reviewing it, I think it's just good to kind of go over and over and over what happens. Guaranteed issue and renewal. Insurers are required to offer and renew coverage without regard for health status, use of services, or pre-existing condition. You know, if you're the person who never uses the insurance, you don't get sick, you haven't been sick, you get renewed pretty easily. If you are now the person who's using the services all the time, who has a number of healthcare conditions, who's going to be a regular customer, you get renewed. So you don't have to be concerned that, you know, like in an automobile accident, if you keep using it, they're either not going to renew you, or they're going to really increase your premium to such a level that you're no longer going to be able to afford insurance. You're going to be able to have access to insurance. Does that mean that insurance is never going to be a financial hardship? No. But it does mean that you're going to have access to it within what's considered to be a reasonable limit as described and defined under the Affordable Care Act. So ensures that no one will be denied coverage for any reason. You can't be denied. Premiums, as I said, to ratings, age, smoking, and geographic areas. I guess I got the "and" in the wrong place. So, rate reviews. So, how can your premiums increase? You get in, you're finally in, and the first question is, in case you know, sometimes you see this with annuities, the first year they pay 12%, the next year they pay 1.5%. So, what happens in year 2? The premiums cannot be increased by more than 10% without public justification. The insurance companies have got to go back to the regulators and justify a premium increase that's more than 10%. And you say 10% is a lot of money. Well, 10% is a lot of money. But when we were paying $70,000 a year to cover 7 employees, we were getting premium increases of 35, 55, 65% all the time. There were a number of years when you just threw up your hands. And we changed insurers every year for that reason. And you don't want to be changing insurers every year. You know, you may be able to go out there and find another one of those 81 plans that might be less expensive, but do you really want to do that and go back to the doctor and say, okay, I've changed my coverage, blah, blah, blah. This is intended to keep your premiums at a reasonable level and keep you from having to make a change based on cost. You may decide to make a change based on what's provided. So there is the 80-20 rule. The insurance companies must spend at least 80% of premium revenues on healthcare and quality improvement. If you're familiar with not-for-profit organizations, you always look at what administrative costs are. How much of the money that you're giving to that organization is being spent for the cause and how much is being spent to administer the cause. This is a similar concept, the medical loss ratio. This company has to spend 80% of its money giving you care and giving you access to care. If they fail to do that, you get a rebate. If the company fails to adhere to the 80-20 rule, policyholders get a rebate. Now, wouldn't that be fun? So, here's my money from the insurance company. So just find that. And I don't hate insurance companies. I just find this to be amusing. So I appreciate my insurer. But I like the fact that they've got to follow the rule, and if not, I get something back. alternatives to the exchange. After telling you all of the things that people have to do and all the mandates that there are, Congress understood that there were going to be both states and individuals and entities that had objections to what were going on. So there are alternatives to buying through the exchange. States may create plans for the uninsured who are otherwise eligible for credits under the exchange. So we're talking about people up to 400% of the poverty level who could get premium credits. A state could basically create a plain bread exchange health plan for individuals to purchase through. And then the state would contract with local standard plans and provide at least, again, the essential 10 health benefits. You're going to get that. And ensure that individuals would not pay more in premiums than they would under the exchange. So the states can offer their own basic health plans. And again, this is their health plan. You're not actually going to buy this through an insurance company. You're going to have the state is going to be your insurance company. And they're not going to charge you any more than an insurance company will, and they still have to offer you this 10 essential state or health benefits, but there may be a reason why your state wants to offer this as well. Honestly, I'm not aware whether Texas has its own state plan. I want to say that I think it does, but I can't tell you that for sure. Anybody know? All right. I don't like to be any less knowledgeable than anyone, but I know I am. The new fundamentals to health insurance. You now have a federal right to health insurance. Any changes in the eligibility and benefits process requires legislation. What we've got here, you want to change it, we go back to Congress. They're never going to change it. I feel like, if you ever anybody watch Gatling Madigan, I mean, they can't agree on anything else. It'll take an act of Congress to make that happen. So, but that's what it would take. I need to stop getting myself lost in these comparisons, but that's what it would require. There's no appropriation. So look at it this way. It's not as though the federal government says, we're going to give $4 billion to the Affordable Care Act this year, and if it costs more than $4 billion to run, then we have a government shutdown. There's no appropriation for this. This is part of the federal government. Whatever it costs, it costs. The plan is in place. There are no enrollment caps. Company can't say, got too many people, everybody's in. There are no waiting lists. You don't have to wait to get on the plan of your choice. How much money would we give if there was no waiting list for a home and community-based service? Personally, I'd give a year's income. Remember, and I'm speaking at this point from my professional philosophy, these wonderful acute health care benefits do not roll over into long-term supports and services, with some exceptions on the Medicaid side. But you're not buying through these exchanges, you're not buying the long-term services that individuals with disabilities or the aging population might need. So where there are waiting lists upon waiting lists. The Texas exchanges, as I said, operated by the federal government. Blue Cross Blue Shield, the best choice PPO, is the basic health plan. So apparently Texas has chosen its own health plan. Doggone, who knew? Bayard County, let's just move around. Consumer assistance in Bayard County is the Bayard County Hospital District. You can go to healthcare.gov, as I said, and click on local help. And by the county hospital district being the consumer assistance, that's where you're going to find your navigators. So I wonder what they wear. What does a navigator wear? So it should have a costume like a super lawyer. I always thought we should have capes. Open enrollment, 10/1/13, we're in it through 3/31/14. Coverage does not begin until January 1st, 2014. All of the issues that I talked about earlier, no annual limits, no lifetime limits, all of those things, some are in place now. All will be in place by January 1st. We're at the open enrollment because in the same way as Medicare, if we didn't have open enrollment until January 1st, nobody would be covered until later into the year because it takes that long, obviously, to process the application. So the idea of open enrollment is that you go in and you enroll and get into the plan. If you don't enroll, in a health care plan by March 31st of 2014, and you are not insured, there will be a penalty leveled against you. You will pay the tax that Congress has levied if you're not covered. One of the issues that's come up is that people are confusing open enrollment for the healthcare exchanges with open enrollment for Medicare, which runs from 10/1 through 12/31. So for your own purposes and whatever population that you serve, if you have clients who are on Medicare, make sure that that's not confusing for them. My husband is the state director for AARP in Texas, and that's an issue that they're running up against on a regular basis, is that some of the AARP population is thinking that their enrollment is extended through March 31st. That's not the case. And many of you know that Part D enrollment is different, so it is not difficult to get confused about what an enrollment period is. But for the rest of the country, those of us who are non-Medicares, open enrollment for buying an insurance plan under the Affordable Care Act, October 1st through March 31st of 2014. Resources. There are a lot of resources, and some of them are policy-based, and some of them are practical-based, and some of them are both. So I offer these to you, and I urge you to go to them if you need this information personally and professionally. Healthcare.gov, the Kaiser Family Foundation. You know, I'm really not sure who Henry J. Kaiser was. I need to Wikipedia him, but his family foundation, as many of you know, is the go-to place for healthcare issues in this country. And the Kaiser Family Foundation, from March 24th of 2010, the day after this act was passed, until now, they have been on this. They are all over it. They know about it. You can go in there and read as much as you want to read. They have navigators. They have premium subsidy calculators. They're all over it. So go to kff.org/healthreform, and you'll get all kinds of information. The Center for Budget and Policy Priorities, again, the website is listed there. It's a great resource for all issues, including Medicaid issues. So if you get confused about the interaction between Medicaid and healthcare reform, that's a good place to go. Also a very good policy place to go if you want to study more about what the policies are behind all of this. In Texas, you want to go to www.tdl.texas.gov/ all of those things. And I just couldn't make it write healthcare together. And that's, that is also an information-based / navigator type website. Again, the exchanges run through the federal government. You want to go through healthcare.gov, but that's the Texas site to get information. And then you also can go to .gov pubs consumer / CB 105. So those are two good Texas resources to find out more. The Affordable Care Act is a reality. It's here. We're now all required to have health insurance or to pay a fee if we don't. That fee will be levied on the tax return. There are many choices from which we can all go through the 81 plans. Patty, you going to stop me and ask me to talk about bronze, silver, gold, and platinum? I'd rather you ask it afterwards. Yes, my wonderful colleague, Patty Sittler, for anybody who's in San Antonio and does not know Patty, it is your loss. She's a tremendous human being, a wonderful lawyer, a great practitioner, a caring person. So she is. So you better really ask me a softball question.
This goes with kind of what we talked about this morning, and I was at a conference last week sitting with an individual who said that, oh, no, you don't want to go to the public exchange because the public exchange is going to charge you an added premium because it's insurance companies coming into Texas. You want to go to the private exchanges, and I can send you, if you call me, I can get you to the private exchanges that are going to be less expensive. And so my question to you is, what is a private exchange? Is that, he said, if you call the public exchange, if you go to the government website, they won't tell you about the private exchanges, and so you'll be paying a higher premium. And I'm thinking, well, I don't know. Are there private exchanges here well, in Texas, and he's telling me, we put these together and it's really great, and if you go with us, we're going to be able to get you really cheap premiums.
I'm from Florida. We have swampland. There are only two factors in this equation. One is, and the biggest is these healthcare exchanges that, like the others, are regulated under the federal government. I'm guessing, Patty, he's referring to a state plan, but I mean, there is no public-private dichotomy. There is no, there's no, upper class country club where you can go and buy, something else. So I just don't. Yeah. And that's, yeah, we'd always worry about exploitation. So there's no difference between those. And one of the things that it raises for me, and because I just talked to for a minute ago about, a very, very high income population, you can buy, there are 4 categories of plans that you can buy: bronze, silver, gold, and platinum. So that basically, when you're comparing the policies, what you're going to be comparing in these 81 policies are just the same things that you compare now. If you've ever looked to buy health insurance for your company, as I have for many years, what are your deductibles, what the annual deductible, what's the per patient visit cost, all of those, out-of-pocket costs for emergency services, those kind of things. Those are the differentiators between your bronze, silver, gold, and platinum plans. So, if you have tons and tons of money and you want to spend tons and tons of money on healthcare, you can still do that. If you don't want to spend tons and tons of money, you can still do that. And that's where your own personal health situation is going to come into play. And so, once you get past what the regulations are for the people who are allowed to sell you insurance, and I mean, once you get through that portal, then you're able to look at what do I need and what can I afford. It's not quite as regimented as perhaps it's been made to sound. It's, you go out and buy health insurance, and yes, ma'am.
ObamaCareFacts.com last week, actually, and I'm wondering, I'm a care manager for 7 people, and to include myself, we have Medicare, Medicaid, TRICARE. If we already have insurance, we don't have to do anything, right? We don't have to do anything. We're good to go.
You're good to go.
We're good to go. Yep. And when I read ObamaCareFacts.com, I understood that if I don't want to get insurance, I don't feel like it, I don't want to pay the deductible, it's none of your business, and then tomorrow I go to the emergency room in a car crash, I understood that I might have to pay for that entire bill. But what you said, it's just a tax. Is that right? You don't have to pay for the whole ER visit or the whole ICU visit. It's just a tax. Because now I'm wondering.
That's an interesting question. But I'm gonna think this through real quickly and say, you're gonna have to pay that $695. You're still gonna have a bill at the hospital.
Right.
And it's gonna be you're still an uninsured at the hospital, and they're still gonna send you a bill, and you're gonna pay $695 for not having the insurance. Mm-hmm. Because that's of course, that's the hospital's concern. Yes.
Because the whole website was the government is no longer going to pick up the bill. You're going to have to take some personal responsibility. And when you do get on this exchange and you do pick the program that you want, does every provider cover every plan, or does that kind of fall into let me get all the shades right, the bronze, silver, gold? Does it fall into that? I'm not sure how to ask that question. Do all providers cover all plans? I'll just leave it.
Do all providers have bronze, silver, gold, and platinum coverage? I don't know.
Yeah, I guess I'll look that up.
So, I don't know. I say freely. I'm going to go up here and then I'll go back there. Yeah. Go ahead.
So in San Antonio, it's really hard finding physicians who take Medicare, and so in San Antonio, it's really hard finding physicians who accept Medicare. We're a very big retirement community for military, for active duty retirees. It's hard finding providers who take TRICARE, for example. And so I guess I wonder, are physicians or hospitals required to take the insurance that people are required to have?
Yes, and I think that the point is that in San Antonio, it's very hard to find physicians who will accept either Medicare or TRICARE. So in a correlating fashion, is it going to be very hard to get a physician to accept the insurance plan that you might have chosen? Is that, okay. When you are choosing your plan, you're going to be able to see the providers who are going to accept, as you do with any other insurance. I mean, when I called to get a new doctor's appointment this week, it was, hi, I'd like a new appointment. What is your insurance? And I thought, really? Not even having, how's your day going? So, and I said, I have United Healthcare, moving right along. So I think it's going to be the same thing. If you tell them, if they agree to be part of the exchange, if this insurance provider is providing through the exchange, it has to pay out benefits to the extent of the policy. So, I mean, does that make sense? Makes sense to me.
So does that mean that the physicians can not accept you as a patient?
The question is, can physicians not accept you? Okay. If your physician, again, if your physician has told Prudential that it's going to accept, a Prudential insurance, then the physician's obligated to take Prudential. If the physician says, I don't want your Prudential, I want United Healthcare, the physician has to take United Healthcare. The physicians are not mandated to take the care. You can still privately pay a physician. There's nothing here that says you can't go in and pay out of your pocket every single cent. There are still boutique practices where physicians don't take any insurance at all. So let me go to the back.
Back here. Well, the other problem is that the physician will say he's not taking new patients at this time,
Yeah.
which blocks you from getting a physician to begin with.
No
So then
involuntary
what
servitude.
happens then?
There's only, even with this program, there's only so far you can go. So to my knowledge, there is no mandate that a physician, accept new patients. I may be wrong, but I'm not aware of anything that says that. Now you all are giving me lots of questions to answer.
It's all about the bottom line for the physician. They have a practice the physician has a practice to run. They need income. So regardless of the Affordable Care Act, it's still going to be an issue to find providers that are accepting new patients. That's not going to change, unfortunately.
Yeah. I was really surprised when I moved to Austin a number of years ago because, I come from the west coast of Florida. If you were a physician who didn't take Medicare, you weren't a physician. Those are some of the most populous over 65 populations in the country. They are, actually. And I heard a radio program in Austin about how few physicians took Medicare, and I thought I was hearing it wrong. I literally thought I was hearing it wrong. I couldn't imagine such a thing. And as you know, there have been controversies over what the payment rates to physicians are going to be. There's a lot of adjustment going on. And I'm sorry I don't know that. I really don't know the answer to that question about physicians. It's not something that's been in my realm. But now I'm going to go look it up. And that's probably the final word that I'll give to you, although I have more time to give more words, and I'm happy to answer more questions. Or one of the things I would say to you is, this is not going to be a perfect system. Thoughts go out of my head so quickly. Physicians can't mandate.
Do you know of any way for a layperson to go onto the healthcare exchange? Like, for example, my employer is going to give us coverage, and I'm probably going to be happy with that because my personal healthcare costs are not going to exceed 9.5% of my income. But I'm seeing all kinds of information floating about, whether credible or otherwise, about these high deductibles. Is there a way for me as a RN case manager at a hospital to verify what's correct so that I can counsel my uninsured patients? Do you have anything to
I'd
add?
recommend that you talk to a navigator. They, as I understand, are very well trained It's going to take a while to get enough navigators, but that's what I think is probably going to be your best guess, because I think if you're going to go online and try and do that, you're going to run up against questions you can't answer, and you feel stuck. Patty, did you have a different question? People who choose to receive their health care through the VA can still receive their health care through the VA. They could. No, because they have coverage. Anything else? Yes, ma'am. Yes, I understand. I understand what you're saying. There are VA benefits, some of which are health care benefits, some of which are pension benefits. Patty, are you VA certified? No. Who is? Carol? Come on, Carol. Good. Carol, move right on up here. I think the issue is that the VA has benefits. Would you describe those benefits as being health insurance? I mean, they provide health care. So,
Wow. I'm sure there's something in the act.
I could have said that. If I can latch on to a laptop before I leave, I'll get you that answer.
Because they're eligible for health care.
Right. That's my thinking too, is that they are receiving health care. So that if you're a veteran, I don't know how you could be mandated to buy through an exchange when you already have an eligibility to get health care through the VA.
I might be able to answer that. I'm a retired military. My husband and I are both, we both have TRICARE. I'm 40% disabled. My husband's 60% disabled. So he gets a better rate, if you will. He gets more benefits, if you will. I get the very basic, but he gets more because he's more disabled. But it's under TRICARE. It's not necessarily under the VA, or they're married.
But under VA, your 60% and your 40% is basically the same. Where the benefits change is when a veteran is 70% or service-connected, or when he's 60 with unemployability. So VA, and I'm pretty much feeling that the VA, it's not really synonymous with insurance, because the VA, that is a benefit that the veteran has earned, and sometimes his widow. They've earned that, so it's not like an insurance. It's an insurance in that they know they're going to get health care, but it is not, I don't view it in the same way you would view the whole package as insurance.
That's a really, really important question. I'm sorry that I can't answer that this moment, but I don't want to leave without being able to, so I'll look it up and pass the answer along. I'm going to go to the back and then.
Okay. The 70% service connected, if they need home care, they will get it if it's related to why they need the home care, and then that's very limited. So once that's over with and it's ended, and if they need some more, they're going to have some type of insurance.
But remember that, that there is, you're going to have to buy a policy that offers that kind of benefit. And I don't know how many policies are going to offer that kind of benefit, and the cost I would think, is going to be pretty high. So, and I'm just thinking this through in the long-term scenario. Yes?
I just Googled it, and it says that if you are a veteran with TRICARE or enrolled in the VA health care benefits, you're not required to make any changes. It doesn't describe what that means, or what the health care benefits are, but you're not required.
Don't you love Google? And actually, because that makes sense. You are not required to buy through the exchange, which means you're not going to be taxed because technically you're not uninsured, but you can enroll through the exchange to get the coverage that you might not be getting through the VA. Healthcare.gov. So, good websites. But I mean, that makes logical sense, at least. So, and that seems to be followed up on what was on healthcare.gov. And I'm sure, or I'm not sure, but you could go to the VA site, I would imagine, too, and get some information.
I just want to clarify, state employees are exempt from all of this, right?
State employees exempt? Anybody want to take that on?
That's what I was taught in the last training that I did on this insurance thing, and I'm still confused.
If you have insurance.
I am too. Are you a state employee?
No, but they're exempted. This is state employees.
Okay. Because you're under basically a group plan that's offered to you through the state. I'm not aware of any exemption. That doesn't sound like an exemption to me. It sounds like you have group insurance. So, can't you see how clear it all is? So, and in lieu of standing up and feeling any less educated, I could just have Carol come up. So, also, yes, also a fabulous practitioner. I'm sorry, Carol, didn't mean to leave you out of that. There's some really wonderful practitioners in this area. All right. Could just lock you in here and say, now for the next 10 minutes, or I could say, there probably is still a few Twix bars left out there. Thank you. I hope that this gave you some basic information. This is by no means everything that you need to know. Go forth and purchase. Thank you.